Hi, I am so happy to see you in the program of 3 p.m. 3-point medics. So far, we have been discussing about hyponatremia. So, whenever you find hyponatremia, the most important 3 investigation, I want to list it out. 1. Serum osmolality to find out whether it is true or pseudo hyponatremia. Once serum osmolality is low, less than 275 milliosmolality, then you are very sure that you are dealing with true hyponatremia. The next step would be the game changer, urine osmolality. When you do urine osmolality, you will always look into whether it is below 100 or more than 100. So, out of 16 causes of hyponatremia, only 4 causes can produce urine osmolality less than 100. What are that 4 causes? You can remember the code word BPT, Bachelor of Physiotherapy, BPT-I. So, what is B? B for beer-potomania, P for psychogenic polydipsia, and T for T-toe syndrome, and I, inappropriate administration of off-normal saline or 5% exos. These are the only 4 causes which can produce urine osmolality less than 100. But when you have urine osmolality more than 100, that means obviously you can rule out these 4 causes. Then you have 12 causes. These 12 causes can be segregated into 2 groups by means of urine spot sodium. If urine spot sodium less than 40 or more than 40, if it is less than 40, urine spot sodium less than 40 means there is some hypovolemia in our body, due to which kidneys absorbs all the sodium from the urine. That's why your urine spot sodium is less than 40. The causes of hypovolemia, it is either true hypovolemia, secondary to diarrhea and vomiting, intestinal obstruction, burns, sweating, or it may be a false hypovolemia. All the 3 important organ failure, cardiac failure, cirrhosis of liver, and nephrotic syndrome, where total body water may be very high in the form of excess fluid in interstitial space or otherwise called edema, but the intravascular volume will be very low because of edema. So, what happened? Our body will sense as a true hypovolemia. That's why this organ failure, you will have urine spot sodium is less than 40. Then you have urine spot sodium more than 40 means you have 4 important causes. Very common causes would be thiazide diuretic, and second one SIADH, then 2 endocrine deficiency, Addison disease and or mineralocorticoid deficiency, and you have hypothyroidism and cerebral salt wasting syndrome. Out of these 4 causes which is responsible for urine spot sodium, the most important cause would be thiazide diuretic and SIADH. Thiazide diuretic, of course, when somebody presents with hyponatremia and altered sensorium, when you look into their current prescription, when you find either hydrochlorothiazide or chlorthalidone, then probably you could say this is thiazide diuretic. Then in that case, definitely you can easily pinpoint the cause for thiazide diuretic or non-thiazide diuretic like chlorthalidone. And in fact, the next cause would be SIADH. SIADH, we clinically come across so many causes. SIADH generally, how will you arrive that SIADH? So, every month we witness 1 or 2 patients of SIADH. Last month, one patient presented with altered sensorium, found to have sodium level around 117. Then we did serum osmolality. Yes, serum osmolality is around 251. So, it is confirmed that it is true hyponatremia. Then we did urine osmolality. Urine osmolality is 246. So, less than 100 or more than 100. So, less than, it is not less than 100, more than 100. So, what happened? 4 causes I have ruled out, BPT-I. Then after that, more than 100, that means we have another 12 causes. We did urine spot sodium. Then urine spot sodium showed 116. So, that means we have comfortably ruled out hypovolemia as the cause for hyponatremia. Then since urine spot sodium is more than 40, out of 4 causes, 5 causes, as I told you earlier, SIADH and thiazide diuretic should be thought of always. So, we checked their prescription, we couldn't find any thiazide and non-thiazide diuretic, even loop diuretic as well. Then another important cause is SIADH. So, what are the additional findings that will strengthen SIADH? So we did serum uric acid. Some uric acid is only 1.6. So serum uric acid will be very low. Then always in SIADH you have to rule out hypervolemia and hypovolemia. Most of the time SIADH they will have normovolemic or slightly euvolemic. Slightly hypervolemic. Then we are very convinced that this patient neither have hypervolemia nor hypovolemia. In fact, there is no evidence of organ failure, and in fact we did serum cortisol which is normal, ruling out Addison disease. Then we did thyroid was normal. Then we comfortably made the diagnosis of SIADH. So few points I want to say about SIADH. What is SIADH? It is syndrome of inappropriate ADH. So the term itself clearly says that inappropriate. So what do you mean by appropriate and inappropriate? So ADH normally causes absorption of water from the cortical collecting duct and tubules. So the main purpose of ADH in our body is water absorption. So whenever you have hypovolemia, especially more than 15% decrease out of your total body water, that will stimulate ADH to absorb more water from the kidney to compensate that 15% of hypovolemia. So whenever you have hypovolemia secondary to any cause, if it is more than 15% of your total body water, then automatically your ADH will be stimulated, which will absorb your sodium, which will absorb your water from the urine. And another important stimuli for ADH is increased osmolality. So for example, when you have severe dehydration, that means water loss is there. For example, typical example is sweating. In sweating, what happens? More than sodium, it is a water loss would be more. When you have more water loss, what happens? The plasma concentration of electrolytes, especially sodium, will be increased in relative value of water. I mean, when you have sweating, what happens? More water loss will be there as compared to sodium loss. So what happens? So your water loss will be more, but sodium loss would be minimal. So what happens in that situation? What happens? Your sodium concentration is increased in relative to your great water loss, which will cause increased osmolality. Or for example, when you have hypernatremia, that causes more serum osmolality. So whenever you have increased urine serum osmolality, so our ADH will be stimulated. ADH will absorb more water. So what happens? The water will be absorbed in the body. So this water will dilute our plasma. So what happens? Your serum osmolality will come down. So two important causes for stimulation of ADH is one, pure hypovolemia, more than 15% of our total body water, and second one is increased plasma osmolality secondary to severe dehydration, or it may be pure hypernatremia. So these are the two conditions which will cause increased absorption of ADH. So other than these two causes, if ADH is stimulated, then it is called inappropriate. Appropriate means either you should have increased osmolality or you should have hypovolemia. If both causes are not found, but instead of that, due to some other cause, if ADH is stimulated, then it is called SIADH. What are the other causes? Yes. Sometimes what happens in the brain problem or in the pulmonary problem, even the tumor can secrete ADH. So inappropriately, that will cause this SIADH, or pain, even severe vomiting. These are some kind of non-osmotic stimuli which is responsible for ADH inappropriately. So when ADH is stimulated inappropriately, what will happen? Enormous water absorption in our body from kidney. So when you have enormous amount of water in our body, naturally what happen? Your sodium is diluted. That's why you developed hyponatremia in SIADH. So when you have enormous amount of water in our body, what happen? Patient serum osmolality or plasma osmolality comes down. So you have hyponatremia, following which you have decreased serum osmolality. 2. So what happens when you have enormous amount of water absorption, more and more venous return in our body, which will cause our atrium is dilated. Okay, so more venous return, so right atrium is dilated. When right atrium is dilated, when atrium is stretched, what happens? Atrial natriuretic peptide is released from the atrial muscles. What is the role of this atrial natriuretic peptide? This atrial natriuretic peptide causes natriuresis in the kidney. So more sodium and water will be excreted secondary to increased atrial natriuretic peptide. So because of that, more sodium is excreted in the urine. That's why in SADH one of the criteria is urine spot sodium is more than 40. Why urine spot sodium is more than 40? Because of SADH, more water reabsorption in our body. More water reabsorption causes more venous return. Right atrium is dilated. Stretched atrium releases atrial natriuretic peptide. Atrial natriuretic peptide causes natriuresis in the proximal tubule. So more sodium excretion in the urine causes urine spot sodium more than 40. So another criteria is fulfilled. So one end it is absorbing more water by means of SADH, I mean inappropriate ADH secretion. Then another end, atrial natriuretic peptide excretes the water through the kidney. So what happened? You may not have water retention because ADH is aggressively secreted. But to counteract that, atrial natriuretic peptide also secreted. So both neutralizes each other, I mean in the effects. So what happened? There won't be any water retention. That's why in SADH one criteria is they won't have any edema. So that's why they are always euvolemic, or we could say slightly hypervolemic. And second one, why serum uric acid is very, very less? Yes. Normally what happens when you have hypovolemia or dehydration, generally our body will cause more water absorption from the kidney and as well as uric acid. Uric acid also will be absorbed secondary to hypovolemia. But when you don't have hypovolemia or when you have normal volume status, there is no necessity to absorb uric acid because there is no reabsorption of water to counteract hypovolemia. So naturally uric acid won't be absorbed, so uric acid will be less. That's why serum uric acid will be always lower value in SADH. So please remember that when you fulfill all the criteria for SADH, please remember that SADH is not the diagnosis. SADH has some hidden causes. You have to explore the causes. This patient also, we diagnosed that patient had SADH, but we tried to evaluate. Patient had weight loss and long-term smoking history. Chest X-ray revealed one SOL in the lung, turned out to be small cell carcinoma by means of biopsy. So ultimately small cell carcinoma in the lung that has secreted ADH inappropriately without presence of hypovolemia, without presence of increased plasma osmolality, which resulted in SADH. Of course, we are going to end the session of hyponatremia in coming few sessions, but this nothing but this will be an one shared discussion. I strongly believe it. But even though hyponatremia is the toughest one, then during my postgraduate days, this SADH is the passionate diagnosis often made by my beloved professor Edwin sir, which prompted me to get into SADH in more detail. So when you are accustomed to evaluate hyponatremia in the form of serum osmolality and urine osmolality, urine spot sodium, I think that over a period of time anybody can easily acquainted with evaluation of hyponatremia. But I am very sure that irrespective of the specialty, cutting across the specialty, I could say any patient you find hyponatremia, you can order at least 3 or 4 investigation very boldly. One is serum osmolality, second one is urine osmolality, and third one is urine spot sodium. Then to some extent serum uric acid, and you can do some endocrine profile like thyroid and okay, even serum cortisol and everything. Thank you.